The journey of dedicated venous stents in PTS long-term outcome going and developments. First of all, I will go fastly through a background about stents in vascular science. Julio Barbas was the first to insert a mesh in arterial system, coronary system for revascularization of coronaries. This is cross-sectional, shows the difference between the histological layers of arteries and veins. This is only to get refreshment with some cornerstones regarding arterial angioplasty and its response. I start to show this because most of, or if not all of vascular practitioners are oriented with arterial angioplasty. Intimal hyperplasia is adaptive response of arteries and veins for any pathology affecting them. It is also a pathophysiological response to therapeutics going intravascular. What is the outcome of future for arterial stents? We are adopting drug coating balloons, debulking technologies, stem cells, and nitinol stents. What is philosophy behind putting stents in the veins? We have to keep in our minds that this is the response of veins to angioplasty and thrombosis that ends by synechia and chronic occlusion of the veins. This is the intravenous accident of synechia. As you can see, it's not atherosclerosis at all. This is the common sites of naturally occurring compressions of iliac veins and external iliac veins that ends by synechia even without DVT. This is the classification of central venous occlusions occurring in innominate and subclavian veins. Regarding venous interventions, to be ready for venous interventions, we have to know these points. Arteries are pulsating while the veins are not. Arterial flow velocities are different. Arterial disease affecting elderly patients. Most of arterial diseases affecting lifespan, unlike venous pathology, it affects young generations. Arterial disease are mostly atherosclerotic, while venous disease is synechia. Stents in the veins might migrate because the venous flow is getting from smaller to larger rather than arterial goes from larger to smaller. Starting points for venous intervention. We have to know that venous dilatation, unlike arterial dilatation, is very painful. That's why we postpone venous interventions for resisting cases for medical therapies like pain management, compression, stocking, and limb elevations. Bypass surgeries are very few and scanty for venous diseases. Venous stents is changing the role of and the outcome of venous pathology. Because of fibrous nature of iliac vein lesions, angioplasty alone is seldom effective. Venous collaterals are not efficient for relief of venous symptoms, unlike arteries. When you have, if there is arterial occlusion and well-developed collaterals, it might relieve the pathology. Large caliber stents are needed for venous interventions. Specification of venous stent, it must be large one. For smaller veins, we have to do arteriovenous shunts. Long-term patency is needed as the affected group are younger patients. Stents should have large length, diameter, flexibility, and radial force. Venous dilatation is very painful. Clear images should be available for venous interventions. We used to do ascending CT venography. MR venography has a place. Direct subtraction angiography is okay. Venous duplex has limited clarity for the pathology. Intraoperative, we have to do intraoperatively duplex machine ready. General anesthesia, the dilatation is very painful. Cath lab versus C-arm dedicated vascular, and of course IVUS catheter, full anticoagulation. After successful venous stenting, we secured puncture site, clopidogrel for 6 months, anticoagulation according to the pathology, follow-up for 1, 3, and 12 months, venography when symptoms occur, re-interventions when indicated. Lifelong patency of the stent is the aim. What is the dilemma for venous stenting, making it different from arterial stenting? That's why for the previous reasons and different pathologies, developed Silver Vena dedicated stent, sinus venous, Vichy, Apri, and Venovo. This is the characteristic appearance of each stent. Some trials is going on, and some of them finished regarding some of dedicated venous stents like Silver Vena and Vichy and Sinus Venovo. Each of them has a specific complication. For example, Venovo stent has mechanical deployment failure. Vichy has a stent migration. Apri and Silver Vena has higher rates of intervention and stenosis and thrombosis. What is the limitation for venous stenting and angioplasty? Venous angioplasty and stenting is a relatively new technique with lack of long-term follow-up. I think the era of dedicated venous stent for 10 or maybe 15 years maximum. So they were deployed for young patients, and we need to know what is the follow-up for 10 years, for 20 years, for 25 years, and etc. Up to date, multicentric randomized controlled studies are different types of dedicated venous stents are going on. Dedicated venous stents are very expensive. The standard use of stents in management of femoropopliteal obstruction has not been adopted because it has low velocities. Given the outcome achieved by the trial is not reproduced, persistent concern for increased risk of acute thrombosis and stent fracture and stent stenosis is occurring frequently. Future FARC, atherosclerosis is an avoidable disease, but theoretically most of venous disease are avoidable. Dedicated venous stents will be lifelong patent, has easy deployment, free of fractures, free of migration, free of clinical relapse, more affordable to reduce the price. Radio frequency with an assist of recanalization may be adopted. Unanswered questions up till now for these stents is what is the role of drug-eluting coated balloons for venous stenting? Do debulking catheters have any role? What about genetic engineering to control intimal hyperplasia? Will venous diseases pathophysiological significantly decrease the number of venous interventions, DVT prophylaxis? In conclusion, certain chronic venous lesions, angioplasty, and stenting is feasible. For important venous pathological and anatomical criteria, there is strong indications of developing dedicated venous stents. The vast majority of patients having venous obstruction are middle-age group with expected normal lifespan, which reflected the need of long-term patency of the stent. Effective venous stent obstruction, durable recanalization should better than having metal behind. Thank you for your attention.